Okay, so today we're going to talk about drugs affecting the endocrine system. You can see based on the number of slides that we have in this section of around 120, this is a long section. So depending on how long this takes, I may split this up into two videos because we could do an entire semester just on this section, with diabetes and hyperthyroidism and all those diseases that go into this. It could be a long one, so I may end up splitting this into two videos just depending on where we get, how long it takes. So an overview, we're going to review the endocrine system, hormone regulation, and then drugs affecting the endocrine system. You got bisphosphonates for osteoporosis, hypothalamic and pituitary hormones, exocrine pancreatic enzymes, diabetic agents, and thyroid and antithyroid agents. The diabetic agents, that's not in order. Diabetic agents are last because it's such a large section, and I've added several slides at the end of it to help with helping you treat your patients. And again, I'm not going to talk about all of these. As far as just the hormones and everything, we're going to jump straight into the medications. So bisphosphonates are used to treat osteoporosis and Paget's disease. No longer treat osteopenia without specific reason, such as like long-term treatment with glucocorticoids. We know that glucocorticoids or systemic corticosteroids decrease our bone mineral density. So if a patient's going to be on them long term, then you may go ahead and start a bisphosphonate. The most significant bone loss with aging is the femoral neck and the lumbar vertebrae. Those are where patients are going to have the biggest difference in their T-scores, or you'll notice that on a DEXA scan. If you look at the guidelines for treating osteoporosis, it's pretty well defined. With who you should be looking at their bone mineral density. It's certain illnesses, and then women when they reach 65, and men when they reach 70, you should be looking at their bone mineral density scans and bone mineral densities, and then possibly getting a T-score to see if they're having bone loss. So some examples of bisphosphonates are alendronate and rosedronate. Those are two of just 6 or 7 that are on the market. Each one has different dosing schedules, whether you're treating osteopenia or osteoporosis, or whether it's for prevention of bone loss, or if it is for someone who's already had an active break. What the bisphosphonates do is they inhibit osteoclast activity, and so it inhibits the breakdown of the bones, thereby increasing bone density. The beneficial effect on bone density mass increases rapidly in the first year and then plateaus after 2 to 3 years, and there's significant GI and esophageal irritation. So that esophageal irritation is why patients have to sit upright for at least 30 minutes to a half hour after they take their medication. They're going to take it on an empty stomach with only water, and depending on the drug, it's either 30 minutes or an hour how long they have to sit upright before they can or after they take the medication. Common adverse drug reactions are diarrhea, constipation, flatulence, nausea, and vomiting. Basically, it's GI is what you may see. Osteonecrosis of the jaw is very, very rare, but it's something you probably don't want to tell your patient that this can happen, or that to be on the lookout for this, because it's so rare. But if someone is on a bisphosphonate and complains of jaw pain, that's something you may want to test for. So patients you want to watch also closely, including the elderly, is patients who are white or Asian, they have a history of eating disorders, long-term steroids or thyroid medications. Thyroid medications themselves don't cause a decrease in bone mineral density, but excessive thyroid medication does. So basically, if you're treating somebody and you overtreat them into hyperthyroidism, you can lead to weakened bones. You want to correct a pre-existing vitamin D deficiency or hypocalcemia in patients before you start bisphosphonates, because they're going to need that vitamin D and calcium to build up the bones before we inhibit start to inhibit the breakdown. So monitoring with bisphosphonates, an alkaline phosphatase is one you would monitor if a patient has Paget's disease. You're going to want to monitor calcium and electrolytes routinely just to make sure they're still getting enough, but they're not getting too much. Excessive calcium can lead to cardiovascular effects and increased risk of heart attacks. So you're going to want to make sure they're not overdoing it, and you want to watch those, especially if a patient's on a diuretic, and that might increase the excretion of those. So again, at patient education, you want them to take it alone with a full glass of water in the morning on an empty stomach, remain upright for at least 30 minutes after the dose, and you want to have adequate calcium and vitamin D intake. And then you want to avoid using antacids or alcohol. So these are the major steps, or safety, tolerability, efficacy, preference, and simplicity for bisphosphonates. It's a very good overview. It even splits out some of the medications for different dosages. You'll see in simplicity at the bottom it says they're available once daily, once weekly, once monthly tablets, and then quarterly and yearly infusions. And the infusions are zoledronic acid, and it's just a way for if patients are very non-compliant or they can't tolerate the oral medications, then they can have an infusion, and they would just have that at an outpatient infusion center. They go in, get their infusion, and then they leave. All bisphosphonates do have fairly equal efficacy when it comes to improving bone mineral density, so it's really based on tolerability and price for which one you would pick. There is questionable efficacy beyond 5 years of therapy, so it's becoming more and more practice now to have a drug holiday after the patient hits 5 years of therapy. Because if a patient is treated for too long, it can actually lead to micro fractures within the bones. So they're thinking maybe that when you're inhibiting that osteoclast or that breakdown of the bone, it's leading, too long of treatment can lead to it looks like the bone's there, but it's like a weakened form of the bone. So it's becoming more and more common to stop treatment after 5 years and then monitor the patient and see how they hold up. So here's a slide on that. If you're at low risk, you're not recommended you wouldn't be recommended to be on a bisphosphonate. Mild risk is you want to go for 5 years maybe before you discontinue or have a holiday. Moderate 5 to 10 years, and high 10 years, and then discontinue the medication. And then on the right side, when you may restart it. And you can see they give the recommendation of maybe using a non-bisphosphonate during the holiday. So for other bone medications, you want to see your chapter. It'll talk about the non-bisphosphonates, the calcium and vitamin D required, how much elemental calcium, usually 500 milligrams of elemental calcium, which can end up being a lot. It can be, I think, 6 tablets of calcium citrate or 4 tablets of calcium carbonate, depending on which one you get. Calcium carbonate's harder on the stomach, So it depends on, and worse for patients who have had GI bleeds and that kind of thing. So it'll tell you which one to go with. So here are your options right here, just overall for treating osteoporosis. So you can see that calcium plus vitamin D, 500 milligrams of elemental calcium plus vitamin D. The bisphosphonates, you have the rankle inhibitor, which is Prolia or denosumab. That is a subcutaneous injection every 6 months that has to be given by a healthcare provider. So I know a lot of those patients are going to those outpatient infusion centers where they can just make an appointment, come in, get it, and then they can leave. You get a selective estrogen receptor antagonist, or raloxifene, can be used for women who may have decreased bone mineral density due to menopause. You can have recombinant parathyroid hormone, or Forteo, which I don't think is used very often. But again, it's a subcutaneous once daily injection. And then calcitonin can be given intramuscularly every other day or as a nasal spray. I think that one is kind of falling out of favor based on other possible medications. I think it really, when it was used, it was when we only had bisphosphonates, but now that these other medicines are coming out for patients who can't tolerate bisphosphonates, its use is really fallen by the wayside. These are just those talking points for each one of those medications. One of the nice things about the parathyroid hormone, or the Forteo, is that it does come in a pre-filled pen. So it's like an insulin pen. They just turn the knob to get their dose and then inject it. They're not having to draw up the dose themselves. So it's pretty easy to use from what I've seen. So human growth hormone, you're not going to see this very much in like family medicine, but the somatropin is recombinant DNA, so it is a human growth hormone. Stimulates the growth and metabolism of nearly every cell in the body, and its uses are for people of short stature with or without normal growth hormone levels. So it's given IM or subcutaneous. It's pretty well absorbed, and the adverse drug reactions are antibody development, hyperglycemia, hypothyroidism, and then flu-like symptoms. So patient education, your total weekly dose has to be divided into 6 to 7 doses. You want to make sure they're aware of the adverse drug reactions that can happen and the monitoring that's going to have to go with that, checking for that. Checking for the hyperglycemia and the hypothyroidism. It's not, according to this, it will not be initiated by a nurse practitioner in a primary care practice. This would be an endocrinology group or office that would start this. Pancreatic enzymes used in cystic fibrosis and pancreatitis. So they are inactivated by pH values less than 4. So if a patient is, patient may need to be tested if they have some kind of hypersecretion disorder or GI issue. You take it immediately before a meal. They do require several days or several times a day dosing. So giving it before a meal also may help it helps with the absorption, but it also may help with remembering to take it. So adverse drug reactions are skin irritation, rashes. You can have stomatitis, nausea at high doses, hyperuricasuria and hyperuricemia. When you're looking at products, you want to watch them. They're not bioequivalent. It says most older formulas are no longer US FDA approved. So each drug is specified in lipase, protease, and amylase units. They're often prescribed in units of lipase. A lot of times what happens if we get a patient who comes in to our facility, we try to continue them on whichever one they were on to begin with. But if somehow we're not able to get it, we try to match the one that has the closest number of lipase units based on what's commercially available. So education with it: do not chew, crush, or drink. Do not chew or crush and drink with water. Avoid leaving them in your mouth. And if the powder spills, you want to wash it off your skin immediately. All right, endocrine pancreatic hormones, insulin. You're going to deal a lot with insulin, especially with the growing number of diabetic patients we have in the United States and pre-diabetic patients. So insulin binds at the insulin receptors on cell membranes, allowing glucose to enter the cells. It also acts in the liver to increase storage of glucose as glycogen. It promotes protein synthesis on muscle cells, and it reduces circulation of free fatty acids and promotes storage of triglycerides in adipose tissue. So you're going to want to look at charts to compare types of insulin. Rapid-acting insulin are those insulins that you're going to give right before a meal. The saying with those is when your meal is hot, you give your shot, because it's going to start to work within 10 to 15 minutes. Within about 15 minutes. So you have insulin Lispro, which is Humalog, Aspart, Novolog, and Glulisine, which is Apidra. I'll tell you, most insurance plans, I think still don't cover the Apidra. It's not as commonly used as the Humalog and the Novolog are. You're also going to have short-acting insulins, which are they last a little bit longer. So those are given 30 to 60 minutes before a meal, and they peak within 2 to 4 hours. So that it's a little bit longer acting than your rapid acting. So those are going to be anything with an R in them. So Humulin R or Novolin R are your regular or short acting insulins. Intermediate acting are going to be your MPH, and those have an onset of about an hour and a half, but they peak in 4 to 10 hours and can have a duration of 10 to 24 hours. So you may see patients using MPH and regular insulin as their mealtime and basal insulin, and that's usually because of price. These are available without a prescription, and I believe there's a version at Walmart. It's made by the same company, but they have a contract for it. It's $20 a vial versus $100 of the other insulins, $100 for the other insulins. And that's a common method. I mean, there's nothing wrong with using regular and NPH as your basal bolus insulin. Then the last category we have is our long-acting insulins, Glargine and Dedimer. There's a few others out on the market right now. These are still the two most common. Onset in 1 to 4 hours, duration of around 24 hours depending on the patient, with little or no peak, and these are used as your basal insulin. Once the patient's on them, there's really no discernible peak in their insulin, so they're great for basal insulin. And here's just another chart. You can see down at the bottom the long actings. There's 5 of them, or really 3 of them on the market now, and then the you'll see down there the insulin glargine U300 or the Degludec U200. That means that's how many units of insulin are in 1 milliliter. So it's usually 100 per 1 ml, and that's all the rest of them are 100 per 1 ml. Those U300 and U200 are the ones they've come out with because as patients progress in their diabetes, they become more insulin resistant, and so a patient who's having to give very, very high doses, numbers of units, it might be better for them to have a more concentrated insulin. But they have to be very careful with that, because any small error in measuring their dose, they're going to get they're at a much higher risk of being hypoglycemic, since it's 3 times the normal concentration. So where you're going to see these again used, rapid acting is mealtime. That's its only benefit. It works for the meal, and then it's gone by the time, really gone by the time you're checking your postprandial blood sugars. Short acting it can be used for mealtime, especially for patients who can't afford the rapid acting, because again they're all name brand. Intermediate is usually like a twice a day insulin given as a basal insulin, and you'll even see a mixture of regular and NPH called 70-30, which is 70% NPH, 30% regular, and they can give that 1 shot a day in combination if they're able to do that to cover their meal times and their basals. So insulin pharmacokinetics, you give it in the abdomen because it's absorbed better there than other sites. Has to be injected, or now there's an inhaled version on the market. I haven't seen it used very much, but I've heard it's it can be used for patients who don't have respiratory issues. It cannot be taken orally because insulin is a protein, so every time we've tried to give it orally, it just gets degraded by the stomach. So it has to be given injected or respiratory. Adverse drug reactions are hypoglycemia. That makes sense. If we give too much or in combination with other medications, it's going to drop our blood sugar whether we need it to or not. And you can have diabetic ketoacidosis. One thing I want to mention under the ADRs, beta blockers mask hypoglycemic symptoms. That's very true. You want to be very careful using insulin in patients who are on beta blockers, because it masks all the symptoms of hypoglycemia except excessive sweating. So if your patient has to be on both, say they're post-MI and they're diabetic, and they're going to be on both, you need to make sure they know that if they're sweating for no reason, then that's probably the only sign that they have that they're hypoglycemic. So you can see pregnant women can use rapid or short-acting insulin because it doesn't cross the placenta. Hypothyroidism can delay insulin breakdown, therefore requiring less units. And the opposite for hyperthyroidism. So as you're adjusting those, you want to make sure that you're keeping that in mind as you're correcting either of those. And whenever you're changing insulins, you want to watch for hypoglycemia. It's always better to cut the dose too much and gradually titrate back up than it is to convert it too quickly. A lot of these, if they're in the same category, like if you're going from one basal to another basal, a lot of them have recommended ratios. You can do it. They may say, all right, change it over 1 unit to 1 unit, or you need to change it from at a ratio of 1 to 3 units. So they'll give you recommendations on where to start. And of course, monitoring, you're going to watch hemoglobin A1C, which gives you an idea of how their blood sugar measurements have been the past 3 months. A1Cs. What's nice about an A1C is your patient can't, in between your appointments, have terrible blood sugar control, and then that last week before they come to their appointment, really, work hard on their blood sugars. An A1C can't be tricked. An A1C does weight more heavily that first month. So if you want to think about it, I believe an A1C, let's say an A1C of 10, 50% of an A1C is really that last month of therapy. I think 30% is the second month, and the remaining percentage is the third month. But it still gives you a good overall scope of how they're doing the past 3 months, slightly weighted towards what the last month of blood sugar control is. You're going to watch renal function, because we know that uncontrolled diabetes leads to renal insufficiency, and then watch for a CBC, or monitor CBC. So here is where you a little chart that shows what blood sugar you're targeting, what insulin you might want to give. So the left column is the blood sugar that you're checking. So what it means is, say the top line, let's say I'm targeting my fasting or pre-breakfast blood sugar. So all the rest of my day is great, but my fasting is high. Then I need to make an adjustment to my bedtime or pre-dinner MPH, or my Dedimer, Glargine, or Degludec, which are those basal insulins. If my pre-lunch is high, but my fasting is good, that probably means, this is the second line, that probably means that my basal is good, because overnight it was great. I'm just having trouble now with my blood sugar post-breakfast, or handling that blood sugar that I got from eating. So my target insulin to adjust there would be my pre-breakfast regular, if I'm on it, or one of those rapid actings they have listed behind it. So this one helps you to know which one you're adjusted to, because most diabetic patients, well, all diabetic patients will eventually get to where they have to be on, they'll be on basal insulin and bolus or mealtime insulin. And especially, that can be type 1s and type 2s. They're gonna gradually, type 1s will be on insulin. Type 2s will, most likely gradually progress to needing mealtime and basal insulin. So, all right. So for patient information, patient education, our goal is going to be an A1C less than 7% for non-pregnant adults. The guidelines do differ. There's two sets of guidelines that people follow. American Diabetic Association has a goal of 7%. The endocrine guidelines have a goal of 6.5%. What they do both agree on is that you do want to individualize it for your patient. If your patient is elderly and is at a risk for falls with hypoglycemia, it's okay if their goal is not 7%. Maybe you want to bump it to 8 or 8.5. Maybe your patient is very healthy and you want to have a goal of 6. You can individualize it for your patient, and what ends up happening is most people relax it a little bit. If their patient, to maybe 8 or 8.5. And with patient education, that last bullet, lifestyle management, diet, and exercise. Even though they're getting insulin or other medications, you definitely want them to remember that it takes some lifestyle management, diet, and exercise to control this also, and to help prevent the progression of this disease. So now we're going to get into oral diabetic agents. And knowing how much we have on this, I may go ahead and stop this one recording here. That way I can focus the next recording on completely on oral diabetic agents, because this list is growing rapidly, has grown a lot in the past 10 to 15 years, and just continues to explode. So I'm going to stop this recording right here, and we'll jump back into oral diabetic agents and then the treatment algorithms that are recommended now.